how much and the severity, the location. For example, if you have somebody with a blood sugar of 450, which is over 4 times normal, and you want to drop it to get their blood sugar back down, and you start loading them up with insulin to drop their blood pressure, drop their blood sugar back down to normal, your brain does not have enough time to adjust to the change in moving all of that intravascular glucose into the cells. If you remove all of that, remember glucose is one of the determinants of osmotic pressure of the blood, right? If you have a sudden shift of glucose from 450 down to 100, that osmotic pressure is going to wind up, you're going to wind up swelling the brain. Because the concentration is going to be greater in the brain, fluid is going to move out of the vessels into the brain, you're going to swell the brain, you're going to kill it. That's why in a person with diabetes, and that particular type of diabetes is called hyperosmolar diabetes, you want to bring the blood sugar down slowly. So that's an example of location. Rapidity of development. Venous pooling usually occurs over a long period of time, days to weeks, versus something like a bee sting, where because of extravasation of fluid from the intravascular space, it occurs within seconds to minutes. Now, edema, this is a term you're going to hear a lot, third spacing. If a patient is said to be third spacing, that means that they're edematous. For whatever reason, you got to figure it out, but a third spacing essentially refers to they're overloaded with extracellular fluid. Transudates. Transudates are clearish to light yellow, like it shows clear, like it shows here. Here's a change on this slide. I crossed that off last night. A transudate is not inflammatory related. It's not allergic related, because allergy is a type of inflammation. So cross that one out on your slide. This is a classic type of edema related to congestive failure. Congestive failure increases hydrostatic pressure, and fluid is going to move out. Also related to the oncotic pressure related to albumin concentration, which is also related to types of enteric or renal disease. Versus an exudate. By the way, the classic description is a low specific gravity, because it's more like water. The specific gravity of pure water is 1. It's more like water, which would mean that it's protein poor. If it was protein rich, the specific gravity would be greater, as it is here. In an exudate. These usually, an exudate is characterized by inflammation, somewhere. Make sure you have that distinction down. There's another thing you need to keep in mind, and that's pitting edema versus lymphedema. In pitting edema, the third spacing involves essentially a transudate in the extracellular space. So when you have a swollen leg and you press on it, you put pressure on it, like the donut head guys we were talking about, and you release the pressure, it leaves a pit. and you describe the pit based on the depth, based on its depth. And what you want to do when you are noting it in the chart is you want to describe it as 1 to 4 plus pitting edema. So a 1 plus would be just a little dimple. A 4 plus would be like this. 2 and 3 is subjectively in the middle. I mean, you can objectively measure it in millimeters if you want. And possibly you should, but most people just look at it and say, oh, that's a 1 plus, that's a 4 plus. That's a little bit less, we'll call it a 3. And you want to note that whether it's unilateral or bilateral. Congestive failure is bilateral, pitting edema. If you have a blockage in your vein, deep vein of the leg, if you have a blood clot in the deep vein of your leg, the venous blood is going to back up against it, right? You're going to increase the hydrostatic pressure behind that blood clot. So your leg is going to swell. Blood will come out of the intravascular space into the extravascular space. Your leg is going to swell. A blood clot, like a deep vein thrombosis, and we'll talk about thrombosis in a week or two when we do that pathophys lecture, is unilateral. So if you have a unilateral swollen leg, you need to be thinking DVT. If it's bilateral, they have rails in their lungs, you need to be thinking congestive failure. We already talked about eating a bag full of bugles. You know, I remember when I was young, when I was a little boy. You know what bugles are? And so, when Mom would bring, we were poor as I don't know what when I was growing up, but every once in a while Mom would bring home a bag of bugles. That was like Santa Claus coming when she brought a bag of bugles. I ate a bag of bugles not too long ago. I did not realize that they're almost little horns of salt. They are the most salty thing I've ever, it's incredible. I don't remember that when I was a kid. Okay. Any questions about this slide? Lymphedema, on the other hand, does not pit. Pitting occurs when you squeeze the fluid out of the extravascular space into the lymphatic channels. In lymphedema, the lymphatic channels are blocked. You can't, when you push on it, you can't squeeze the blood anywhere. I mean, squeeze the edema anywhere, so it does not pit. Again, the reasons for it are listed there. We had this guy over at Good Shepherd, and I think I've mentioned him before. His legs looked like this when he first came there, and it was really difficult to determine with this guy if it was lymphedema or if it was pitting edema, because he pitted, but it was a characteristic lymphedema appearance. He was a horrible guy. The nicest guy in the world, but horrible to try to treat. All right. Common disorders associated with edema are listed here. We're going to go through each of them real quick. Congestive failure basically is decreased cardiac output. Decreased cardiac output can either come from the left side of the heart, the left ventricle, or the right ventricle. I don't know if we talked about this before. We did? Okay, a little bit. We're talking about JVD and stuff. Okay. All right, so just appreciate, though, if your cardiac output goes down, either on the right or the left side of the heart, then it's going to cause a backup of fluid upstream. Okay? So if we look at left-sided heart failure, the backup of left-sided heart failure is going to occur in the lungs. So you're going to wind up with pulmonary symptoms related to that, such as shortness of breath and dyspnea on exertion. In other words, I used to be able to walk down to the mailbox before I had to sit down. Now I can't make it to the mailbox. That's DOE. Before I go any further, there's another type of edema that doesn't fit into one of these categories that you should probably appreciate. Anybody here run the half marathons or marathons? You got one, I know you run, what happens after these, or done a lot of strenuous exercise, you know, what happens after that? So you get horrendously dehydrated when you do this type of strenuous exercise. After it's over, you sit there and you pour on the fluids, right? What happens the next day? Huh?
You can't get out of bed.
Well, you can't get out of bed because you're sore, but yeah, you're puffy. You have you wind up with, after these types of events, you wind up with a volume overload. But one thing I want you to appreciate with a volume overload like that is physiologically you're normal. You have a normal heart function, right? So you're not dealing with failure related to a volume overload from running a half marathon or a marathon. This is a pathological situation here. The heart, back in physiology, and I'm sure Professor Paul will cover this, the contraction of the heart is based on Starling laws, Frank Starling law, right? That determines the force of the cardiac contraction. If that force is not sufficient enough, cardiac output will go down. If cardiac output goes down, the backup goes into your lungs. Right? Also, you wind up with cough because of the pulmonary congestion and of easy fatigability because you're not ventilating well, and orthopnea because of the decreased cardiac output. Pulmonary edema, this is not a pleural effusion, this is fluid because of increased hydrostatic pressure in the pulmonary system. Fluid is leaking out into the alveolar spaces. Claire?
Oh, I was just wondering if there was a name for that other type of edema that you were describing for the extraneous exercises.
It's just volume overload.
Just volume overload?
Yeah, just volume overload. But it's not a pathological process like this.
Right.
But it's one that you're going to encounter in your practice because people are going to come in and say, you know, a day or 2 days after doing something very strenuous, like ride their bike in a hotter than hell 100 down in Texas or something, that what's going on with them? That's why. It's just volume overload. Okay. The fluid shift. All right. Right-sided failure occurs when you're not getting enough cardiac output from the right side through the lungs. One of the problems with right-sided failure, one of the causes of right-sided failure is interstitial lung disease. This results in pulmonary hypertension. If blood can't flow smoothly through the lungs because of interstitial disease, sclerosing, scarring, the pressure in the pulmonary vasculature is going to go up. You're trying to force the blood through this scarred up lung, it's not going to happen. The mortality of pulmonary hypertension is it's horrendous. It's like 80% in the first year after onset. It's horrendously high. Pulmonary hypertension. And pulmonary interstitial lung disease can occur in young people like you as an autoimmune process. It's horrible that, you know, people that are 20s and 30s, once they have pulmonary hypertension like this, you know there's very little, there's nothing can be done really. There's a drug, there's a single drug that treats it, but it's not very effective. So, I hear music, or is that just in my head?
So you have right-sided heart failure due to pulmonary, so it's not necessarily the heart's problem, it's the...
Yeah, it's, so it's a long-standing issue. Left-sided, right-sided heart failure, they don't occur overnight. If you have increasing pulmonary hypertension, the right side of the heart is going to have to keep getting more and more muscular to try to force the blood through there. It's going to become hypertrophied, and that affects the Frank-Starling law, and the ability for cardiac output goes down. So as hypertension goes up, cardiac output goes down. Okay?
So Carlton's lung cancer is why his heart was so big?
Yeah. Yeah.
Oh, that makes sense.
On the left side. On the left
Yeah.
side.
Yeah.
Right, on the left side. And that's what happens in hypertension. The left side of the heart has to contract harder to pump the blood through. You know, obesity, there are a lot of conditions. Atherosclerosis, diabetes produces cardiomyopathy.
This is right one though.
It probably is, okay, here's, Tiana, your question here was the right lung, I mean,
Yeah,
right side?
It was his right lung.
Remember what I said the other day? What happens on the left side, if it backs up through the lungs and affects the right side, cor pulmonale. If you've got heart and lungs affecting each other, it's cor pulmonale. It's a, you know, his problem, a malignancy over time produced this. Okay? We got to figure out where this music is coming from. It's straight above us?
How do you hear that?
I can hear it.
I can hear it.
It's like
You're
right
not
here.
I feel like you have no hearing.
It's like right over here.
Like, it's very faint.
I can hear
I
it.
know, it's selective. It's truly selective. Talk to my wife. It is truly selective.
So confusing.
Oh, cor pulmonale is listed here, okay? Consequences of right-sided heart failure, and I mentioned this in anatomy, you're going to have, because the blood is going to back up in the venous system, in the superior vena cava and inferior vena cava, you're going to have distended neck veins, or JVD, jugular venous distension. Because the inferior vena cava is also involved, the liver is going to be congested. Blood is not going to flow through the liver like it should. Remember, there are two types of blood flow through the liver. One is through the hepatic artery, and then that blood supplies the liver tissue and is drained through the hepatic veins. I didn't mention the hepatic veins yesterday. They're on the back side of the liver. You can't really see them in the lab. They connect the liver to the inferior vena cava. Right? So you're going to have congestion that way. You also have through the liver the portal vein that we're going to talk about today. If there's congestion in the portal vein, that blood backs up into the portal system. You have congestion of the blood in the intestines. Remember that caput medusae we talked about earlier? That it even backs up all the way to there. Okay, dependent pitting edema is what you're going to see with right-sided heart failure because it's on the venous side, and an increased body weight is invariable. Liver disease itself produces edema because blood flow can't go through the liver. Most of the time we're talking about alcoholism and cirrhosis. But you can have cirrhosis of the liver because of viruses as well, like hepatitis or CMV, cytomegalovirus, CMV, or hepatitis, alcoholism. Okay. The thing about the liver is that the liver synthesizes the prealbumin that we talked about earlier. The liver also synthesizes what are called vitamin K dependent clotting factors. When we talk about clotting here in a couple of weeks, we'll go through what those factors are, but if the liver is not functioning, you're not producing the albumin, so you've got that issue related to edema. Also, you don't produce your clotting factors. These people, if they bleed, they tend to bleed badly. And I'll give you an example this afternoon when we're talking about liver disease. Okay. Everybody knows that in clotting there's an intrinsic and an extrinsic pathway. You remember that from physiology. Okay, that's all. This is an example of, it's called nephrotic syndrome. In nephrotic syndrome here, you don't normally pee out albumin. Albumin will not cross the glomerular membrane. It doesn't get into, or it doesn't leave the vascular space normally. It's too big of a molecule. In nephrotic syndrome, the holes that are in the filtration mechanism allow for you to pee out albumin. Albumin loss in nephrotic syndrome can be as much as 4 grams a day, or that's the cutoff for nephrotic syndrome. They usually pee out more than that. Okay. And because they lose that, the pressure, the osmotic pressure of albumin in the blood, they're going to become edematous. And that's what this little guy is showing right here. There is a strep throat. If you don't treat strep throat, there's a very small chance, maybe like 3%, that you will develop glomerulonephritis. Glomerulonephritis will cause leakage of proteins. It's temporary. And it resolves over time. That temporary loss of proteins because of a post-strep glomerulonephritis is called nephritic syndrome. Nephritic, not nephrotic as in this. This is a congenital problem. Nephritic syndrome is acquired because of strep. Because it's self-limiting, it will go away over time. You usually just have to manage the fluids. But the point is, if you have strep throat today and it goes untreated, about 2 weeks later, if you show up to clinic in that 10 days to 2 weeks, and you're puffy and you're peeing protein, and there are some other things you use to diagnose it, you need to be thinking nephritic syndrome, and this is what, I mean, typically wouldn't wait till you were that puffy to show up, but that's one of the characteristics of it, and it has to do with protein loss through the urine.
When you do a UA, when it says protein, is it talking about albumin, or is that?
When you do a urinalysis, the normal protein content is 0. So depending on what type of test you do, you can rate it 1, 2, 3, 4 plus. You have 4 plus protein, or you can actually quantify it in milligrams. So either way, but you sitting here, your protein in your urine would be 0. Now, if you had a urinary tract infection, you're going to have protein because the bacteria is a protein, right? GI disease, we talked about GI disease, not eating, malabsorption. Malabsorption would be ulcerative colitis, other types of diseases of the bowel. And lastly, the inflammatory processes that we talked about with bee stings, poison ivy. My wife, she, this past weekend, or 2 weekends ago, she dyed her hair at home. And she was allergic to whatever the dye was. And so all weekend, she looked like that guy. I mean, all weekend, she was just puffed up. It was just truly, I felt so sorry for her. But understand that in an acute inflammatory process like this, it's not an issue of hydrostatic and osmotic or osmolar properties. The capillaries actually become leaky. They no longer have their tight junctions between the endothelial cells. They open up and fluid just pours out. I mean, it pours out because of hydrostatic pressure, but it's because the capillaries become leaky. Okay? Any other questions? Anything going on in your life? Some of you left yesterday in the lab because Friday is the lab, the lab practical. I have to close the lab at 2:30 Thursday afternoon. So make sure you get plenty of your lab time in before then, okay? All right, I'll see you guys at 1.
Kenny, did you stop?